I met Leslie early in my faculty career at Texas Children's Hospital.
He's become more like a close friend.
Leslie is a force of nature.
I'm Leslie Meigs, and I was one of Dr. Goldstein's patients back when I was 8 years old. I had bacterial meningitis and developed AKI, which led to chronic kidney disease. One day, I woke up and I had a headache. I was achy, so my mom thought, we'll go ahead and take you in to see your doctor. And he said, you know, she looks fine to me, just take her home, let her rest. Over the rest of the day, all of my symptoms progressed. She called the ER, and my mom said she's developing this rash all over her body. It's all irregular shaped, and it looks purple. That's when the nurse said, oh my God, you need to bring her to the ER. Your daughter's critical, she's dying. One of the last things I remember was them putting me on the helicopter and looking back and seeing all my family. And they were holding each other and crying and saying, I love you. So I ended up in a coma for a total of about a month. Eventually I got to the point where I was able to be discharged and I could live a pretty normal lifestyle. And so my junior year of high school, it was a shock to the system when I had an appointment with Dr. Goldstein, and he explained that we had done as much as we could at that point to preserve the kidney function I had left, but I'm gonna need to get a kidney transplant.
I'm Stuart Goldstein. I'm a professor of pediatrics at the University of Cincinnati College of Medicine and the Clark D. West Endowed Chair of Pediatric Nephrology at Cincinnati Children's Hospital Medical Center. I've been a pediatric nephrologist for 25 years. Urine output has actually been overlooked for many, many years. People didn't understand its importance, and they didn't really understand the association between decreased urine output and poor outcomes. And what we also found in AWARE was that if you did not pay attention and measure urine output, then you would miss about 1 in 5 kids who would have had acute kidney injury. We have fought very hard for patients who are critically ill with acute kidney injury to at least leave the Foley catheter in for 3 to 5 days. We estimate that around 20 to 30% of patients in an ICU are going to be at risk for a severe acute kidney injury and would benefit from having early, accurate, and real-time assessment of kidney function, including urine output. It can be a much more reactive and contemporaneous measure of kidney function, really as a theragnostic. We try something for the patient and we see how the patient responds. Creatinine is not going to respond that way, and even novel injury biomarkers are not going to be theragnostic in that way to see if we actually had an effect. We have to wait 6 hours, 12 hours, or even 24 hours to see if things improve for the patient. Seeing what the intervention did and how the patient responded to the intervention would really be a game changer. In the adult world, stage 1 acute kidney injury is associated with mortality. So the long-term implications of acute kidney injury are that patients are at increased risk for chronic kidney disease and ultimately end-stage kidney disease needing dialysis or a kidney transplant. There are data that do suggest decreasing acute kidney injury and decreasing the sequelae of acute kidney injury have the potential to decrease ICU stay and have the potential to improve the quality adjusted life years for the patient.
The ICU is not an easy place to work, and there's so many equally important things going on for each patient. What you're doing in that moment will affect the rest of their lives. in their health. I probably will never be at a point where I'm not depending on a machine or someone else's donation to feel healthy.
This device improves the workflow, improves the accuracy, and improves the efficiency of caring for a patient at risk for acute kidney injury, that patient and all of those patients should have this device available to them.